very honored to have Dr. William B. Lawson as our speaker. He's the founder of the Institute for Reducing Disparities. He's the president of Senior Psychiatrists. He's a professor of psychiatry and behavioral sciences at George Washington University, an emeritus professor of psychiatry at the Dell Medical School, University of Texas, Austin, and an emeritus professor and formerly the chair of psychiatry and behavioral sciences at Howard University School of Medicine. He received a Ph.D. in psychology from the University of New Hampshire and an M.D. from the Pritzker School of Medicine, University of Chicago. And he was a resident at Stanford University and was a fellow at NIH. And he was a professor at various other universities and a recipient of numerous awards, which I won't go on to. He's also the author of over 200 publications and former editor-in-chief of the Journal of the National Medical Association. So,
I am very happy to speak to this audience because of his commitment to the community, and it's something that I've been trying to do ever since I retired for the third time a couple of years ago. Finding out that there's a lot of work need to be done and a lot of work that we need to be built on. We talked about the fact that where have our minds have gone, and part of it is related to the fact that this COVID had a lot of broad societal implications. Something like this happened about 100 years ago, and surprisingly, there was almost amnesia in terms of that event. That is that pandemic of a lot of impact, a lot of people died, but folks forgot about it. And I'm sure psychiatrists have developed ways to describe the impact of why people forget so terrible an event. But I think it lays a foundation for, if you put that behind you, you can move forward. Well, recently we had another event, and one of these has been that there was an outbreak of a virus that was novel, no built-in resistance to it, and the implications has been that for the first time for many of our modern remembrances, we actually had no medical treatment that could prevent death. So there were a lot of deaths, no reliable vaccine, and no confirmed treatment. What it also showed was what happened in the previous epidemic. In the previous epidemic, there were a lot of morbidity related to mental health, substance abuse, suicide rates went up, and people forgot about that. And now we are rediscovering that. Now, is it that between those times that mental illness and substance abuse were not a problem? I think not. I think what's happening is we begin to uncover problems that we had papered over or glossed over and are continuing to persist. In terms of one of the ones has been suicide. And I'll say a little bit more about that. But again, we discovered that the suicide rates is going up in the country. More interestingly, noted that the suicide rate for people of color have gone up substantially. I actually don't believe that. I think the rates have always been high. But for a variety of psychosocial reasons, we simply haven't discussed it or paid much attention to it. And as Dr. Chapman has noted, the increased overdose rates and deaths related to substance abuse, again, rates of death from substance abuse have always been high in this country. But for a variety of reasons, especially with modern technology and the invention of such wonderful drugs, fentanyl, we now discovered that these drugs are not benign entities, that they are major sources of death in our community. I was just had an argument with another conference that's going on very soon, and another part. And one of the arguments that I was making was I was looking at the program, there was no mention of suicide or homicide or substance abuse. What? These are ranked among the top 5 killers of young people, especially people of color in our country. And yet we have major meetings going on in which these factors are ignored. So the consequence has been that for the first time in history, in this country, we've always thought we were in a country in which our life expectancies would be great. Recent studies show that many people in the U.S. are convinced they're going to live to be 100. But in fact, our life expectancy, and remember, many of us, has gone down. Is it because COVID went out and dropped it? No, it's mostly because of the consequences that's been uncovered. The suicide rates, the homicide rates, drug overdose deaths from drug use. So there has been an impact. We can look at it, we can blame it's all COVID's fault, but another way I think to look at it is to say it has uncovered problems that exist in our community that we have long ignored. And part of it has to be related by the reality of history. There's a phenomenon that some states, I won't name them, going to say that things such as racism and other kinds of things are irrelevant, that disparities are an illusion, when in fact, these kinds of factors do seem to affect healthcare, not in a small way, but in a major way. This is just showing you the interesting history of African Americans in this country, which people suffered from, had factors such as structural racism related to things such as slavery, such as long history of segregation, and so forth. And I recently went back and checked the literature and said, what was the life expectancy of slaves? It seemed to be a fairly straightforward question. When I talked to many historians, they didn't have a clue. And but what's been listed is rates such as the 20s. So it wasn't that slavery wasn't a benign institution that just had a lot of social consequences. It also impacted survival of people as well. And in fact, having people coming from Africa to this country didn't just expose them to high-tech technology, because many of the folks didn't get access to the medical technology base at that time. So we now have what we call structural racism, and I like to emphasize that term because what it means is that we're not dealing with people just don't like Black people. It was much more so that built in our system are problems that lead to poor access to care, phenomena such as redlining, that you can't live where you want to be, and yet we now have strong data showing that where you live has a lot to do with your life expectancy. And also, what we're finding, especially in terms of mental health, is the whole issue of underdiagnosis and no diagnosis. And of course, there's a new phenomenon we talk about, weathering. Whenever I go to a mental health substance abuse clinic, folks say to me, "You're a young man," and I'm talking to someone who's 50 years old. I said, "Man, I'm 20 years older than you." What happened? What happened is that those kinds of life events age people at the cellular level when they have persistent mental illness and have chronic substance abuse. This is just some of this documented back when I was editor of the Journal of the National Medical Association. I wrote up some of this in my editorials and some book that will be available for any of you afterwards if you're interested. So what we're dealing with is we're dealing with a world because of problems such as structural racism. We got unmet mental health needs. We got an issue of impulsivity, not impulsivity in terms of something that's intrinsic to a race or ethnic group, but as a survival mechanism in an environment in which you actually have uncertainty, in which you're going to get your lifetime support and health. And then the idea that people of color are somehow more violent than the general population. And I'll come back to that. So we have disparities in terms of diagnosis, disparities in terms of treatment, great access to care issues, and a persisting issue is that, especially for African Americans, there's even less access and then for other racial and ethnic groups. Another book that I'm involved with, going into misdiagnosis or underdiagnosis, basically, mental disorders are not recognized when they occur in the African American community, despite the fact that, like in DC, we have more mental health providers than pretty much anywhere else in the world. Still, folks miss mental disorders. One of the problems is disorders such as depression, mood disorders such as bipolar disorder, and post-traumatic stress disorder simply aren't recognized. And as a result, treatment is delayed, And um, one problem is that not only is it delayed, some people never get treatment. We did a study at Howard University, just a very simple study. It was went out and found out, looking at primary care clinics, how many people had mood disorders or the post-traumatic stress syndrome that you see in combat veterans. And what we found is that over half of the patients had it. Wow, oh my gosh, well, in the city area, stuff goes on. But it was more than that. Only 17% of those folks not only were recognized, but got referred for treatment. So we went to publishers, think this is a novel finding and so forth. Quickly found out, got a lot of resistance when folks said, well, maybe that's just DC area, that's just your clinic. It was soon replicated in other cities around the country. And what we're finding is that, especially for inner city areas, even though there are high rates for post-traumatic stress disorder, high rates for depression, they are often not recognized even by primary care physicians. In addition to that, what we find is that it's not just the providers themselves, it's also the folks that have these disorders, the communities they're in. What the Mental Health Association, and I used to be head of the DC chapter before it disappeared during the COVID, but what the Mental Health Association showed was that many African Americans simply did not believe that they had mental disorders when in fact they did. Depression was often recognized. People believed that if you go to church, use prayer, you can treat many of these problems. And this is despite the fact that I'm frequently contacted by ministers who claim that they can't manage some of these concerns or they need some help. Many of these same people will go to orthopedic surgeons if they break a leg, but they won't if they have almost suicidal depression. So why is this? Well, we find that there's a belief systems. Many people believe that you should, when you have a mental disorder, keep it in the family. People say, people will talk, so they won't get it out. It's not from my side of the family. And so then there's the stigma, the shame, their religious beliefs. Somehow we believe that despite the fact that you can't cure pneumonia, well, there's some cards that they thought to cure COVID. We sometimes have to give prayer or help in terms of providing some treatment. And there's this whole idea, we are a strong people, held widely in the African American and Latino community. Somehow we're resistant to the usual consequences that lead to depression or anxiety. There's a whole idea that, or maybe you have, and actually there's a health director in one place who says that African Americans are from weak stock, that we somehow have been pressed immune systems. This is why we have these disparities. What about dealing with treatment? Well, one of the problems is when we look at our system, we see where the problem is. We find that in order, even when a person recognizes it, first of all, they got to recognize it. And even after they recognize it, they have to go through an incredible system of trying to get services. If they're lucky, they may get to a mental health center, then they go for the mental health center, then they might end up getting out to a clinic, then they get to a clinic. If they're lucky, then they got to go to a hospital. The point is that I hear frequently say, well, we need more mental health services. We got a lot of services. What we don't have is an efficient system for folks to get access to services. And we can say it's the economic system, we don't have 100% care, but it does not relate to the fact that it's not been a strong priority in this country to make access to appropriate treatment a priority. The Obamacare has made a start, but we still have formidable barriers in terms of getting this access to care. So the impact is that what we're finding is that recently, certain things such as suicide is actually increasing in such groups as the African American community. My colleague, Alan Poussaint, made the startling observation that Black people kill themselves. What? Even though if you go and look at historical records, you find that suicide rates were very high when they were bringing folks from slave ships over to the United States. And the recognition, not on that, but still look at the books that said who's the high suicide rate people? Old white men. Well, not anymore. Young African American men have slid on up to become high in that group. This, by the way, is a slide from the interesting tour you should take sometime called Soul Train Cruise. Was built on John Cornelius. Those of you who are old enough to remember Soul Train, American Bandstand, and so forth. And then he committed suicide. And what part of his contributions is to help create a foundation to try to address this increasing suicide rate among African Americans. And the recognition that being wealthy, having a lot of status is simply not protective against suicide. What is protective? Treating depression, having access to services and care. So again, suicide rates are going up very rapidly among the African American community. It's hard to detect because we now got a high rate of people killing themselves from drug overdose. How much of that is suicide and how much is just as carelessness? There's no practical way to determine that because unfortunately dead people don't talk very well. But this is an ongoing issue in terms of recognizing these concerns. Part of it, Black men don't kill themselves. You ask folks, we don't kill ourselves. It's better to be mad than to be bad, and so forth. But bad to be mad. But again, there's a lot of community resistance against the idea and the larger societal belief that somehow we're immune to such things. Part of it has to go again. We have a healthcare system that is not culturally competent. It's not, folks don't know how to ask people. You feel feelings in which life is not worth living. They don't ask it because they don't believe people want to kill themselves in the first place. There's lack of access to evidence-based treatment. We have effective treatments. We find that especially some of our newer treatments, folks just don't get it. And lack of contact with mental health. And also, again, this idea that it's better to be bad, better to be a gangbanger in the neighborhood than to go around and tell you folks, gee, I'm feeling bad. And so I need to hurt somebody. Now, the other one is mentally ill people more violent. Well, if you watch TV, you'll be convinced of it. There's certain congressmen who will tell you in a second that the problem that these murder rate is going up is because we've got a lot of mentally ill people running loose. When in fact, the evidence is quite the contrary. That if anything, folks may be, if not worse, less violent than the general population. And this is just an idea about violence in the community. Some of you saw this very good movie, A Beautiful Mind, show another face of severe mental illness, Russell Crowe, whereas the face of African Americans is somewhat differently. This is just showing you the book on protest psychosis. I encourage you to read. But she noted the point that even in drug ads, they presented the picture that severely mentally ill people were more violent, and therefore you had to develop medications that would stop them in the tracks, as one colleague tells me. So there's almost two myths. One is that violence in the community is related to mental illness, and now one is that's mostly related to Black folks. Reality, we did a study that found that looking at a mental hospital, African Americans were less violent than their white colleagues, counterparts. I had difficulty getting published. Nobody would believe it until it was replicated. And the why of it is interesting. What we found is that the staff was so convinced that African Americans would be more violent that they always moved more quickly and intervened more early in case there were signs of violence. But the point was that they and everyone else believed that somehow African Americans who are mentally ill are extreme risk for the community. Just showing you a case in terms of, I was recently in Austin, Texas, where in the case of policeman shot an unarmed, naked Black teenager because they thought he was in danger. Of course, the naked teenager wasn't armed. More recently, Sandra Bland case led to legal efforts to try to take steps to recognized early that people with mental disorders should be treated and not thrown into jail. Even more recently, here at Petersburg, Virginia, African-American man was considered violent. They piled on him. They literally jumped on top of him, and he died. So these kinds of events, we talk about the risks to people who are not mentally ill, but what we don't really look at is the fact that mentally ill people, unfortunately, are much more likely not only to be violent, but that when they end up with bad consequences, usually not much is done in terms of it. There are no marches for mentally ill Black people dying. So again, what we find is that there's a double whammy. African Americans who end up in the correctional system are less likely to get treatment than their white counterparts. And I was involved in a case in Arkansas where they were treating people who were suicidal by chaining them to the wall. And the case was stop chaining them to the wall. Not a very effective treatment. So we got lots of people who end up incarcerated, as you know, big issue, dealing with these issues from incarceration. Problem of incarceration, not that people who are doing criminal actions are being incarcerated, but that people who have mental disorders are often incarcerated. So African Americans are more likely to be incarcerated. That's the community issue that's widely recognized. And I won't go into the reasons why. There was a time when folks ended up with mental illness and long-term stays and hospitalization. We said, oh, that is bad. And so we had deinstitutionalization, get them out of the hospitals, get them back into the community. The idea was it would be cheaper, the money that will follow the patients as they ran to the community. Well, that didn't quite happen. What we found is that the tremendous rate of growth of the prison population, a lot of them were nonviolent substance abusers, but a lot of them were also mentally ill. There was much more reversion to, I guess, the 18th century before they had mental hospitals. So it was an unexpected consequence of the institutionalization that folks ended up in the street and ended up in jails rather than in treatment facilities. Only 15% of people who are in jail get treatment. So what can we do about this? Just want to know the important point, that take-home message is treatment works. We got to choose between treatment and rehabilitation. So we got this huge double whammy that's going on, because on one hand, folks get inadequate treatment and they're more likely to end up incarcerated. And so what do we need to do for our success? We need more cultural overlay, more psychoeducation, more vocational rehab, and rehab programs for severe illness that are not in jail or locked up, including double trouble, clubhouse, and so forth. We have some challenges, and that is that mental health treatment systems are for predominantly white English-speaking people. In addition, many of our people are not trained to recognize cultural diversity. The social mechanism as well as the diversion. This is just an old slide showing what we already know. Black people are most likely to get treatment from other Black people. Latinos are more likely to get treatment from Latinos. So, and the outcomes are when we have what we call ethnic matching or race matching, there's some really interesting work showing that outcomes are much better. And one of the findings we found is that white people do better when they're treated with Black mental health providers than white folks. That's what. So there is evidence that race matching does work, or even go beyond that. Part of the problem is percentage of African American doctors have not changed much in the last 120 years. We got the same number of providers that we did a century ago for a variety of reasons that I won't go into here. But what that means is that we can't do ethnic reverse matching, so we have to use more training programs. And yet there's strong, as many of you, strong resistance of people to teach diversity education. American Psychiatric Association had got its First African-American president. 2 years ago, the American Psychological Association was 3 years ago. So our provider organizations are not very diverse at all. This is just showing you some resources. We got NAMI, of course, and Mental Health America, Depression Bipolar Support Alliance. There's also now telehealth. One of the developments during the COVID epidemic helped greatly expand services to folks that normally did not get it. And then we have several professional organizations, Black Psychiatrists of America, Association of Black Psychologists, Association of Black Social Workers. That are working to try to offer more awareness and diversity training to the community. So we got some answers out there, but we got to look at, as a friend of mine would say, if you look at broken eggs, you can make omelets out of them. So we got to be creative in terms of developing treatments for our community. Thank you.
Will you take any questions? Would anybody like to ask questions?
I was waiting for you to state explicitly that where you live, if you're a person of color, is not an accident. It's a result of deliberate segregation.
Yeah, I mentioned in passing, there's a whole talk on redlining.
But
on policy, on income, as well as, of course, old lines that were of neighborhoods that were created during, especially in the segregated South.
But the question I wanted to ask was, there's been a dark side of the psychiatric profession, and in certain communities in particular, when one thinks of things like the Tuskegee experiments, there's a well-founded mistrust of the government and the medical profession. But what I want to ask you is, how do we deal with deliberate manipulation of public mistrust, where people, for example, are whipped up into fear and told they should not get vaccinated, or that ivermectin is an effective treatment, or how do we deal with that? Yeah,
well, and some of it's deliberate, some of it's not so deliberate. I was on my church trustee board, I was arguing with a colleague of mine who was saying that he had been told that COVID can be treated if you breathe properly and hum. And so therefore using things like medication doesn't work. I was in the hospital 2 years ago, and it was at Johns Hopkins, and one of the nurses said, "Don't you take that vaccine. This stuff is awful. Don't take it." So there's some of it is misinformation based on previous beliefs. All technology is evil. Everything must be natural. I said, yes, snake venom is natural too, but I wouldn't want to be bit by one. So part of it is some of these persisting old beliefs. Part of it is delivered, I guess, for financial interest. Some of us are now working with multiple groups that are pushing mentholated cigarettes. Mentholated cigarettes are much more preferred in the African-American community. Some communities have taken steps to restrict their use, and yet there are some very prominent ministers who are saying that we should have as much right to mentholated cigarettes as everybody else, and are fighting these kinds of efforts. And some of it's financial, but some of it is also that folks should know better, deciding that freedom means freedom to do things that are not healthy. And that is a tough one. That's why organizations like this one and other nonprofits, and also our persisting information, that's why I'm working with the churches. There's a group that's working with barbershops and beauty parlors. Other groups are working at grassroots level, see what you can do. Ideally, if you can work with politicians, that would be so much the better. But what I quickly found is that I think the good news is that politicians are us. That to become a politician, you don't have to know much of anything. But the bad news is you have to educate them. And what I found is that some of the more extreme other side politicians will listen. When I was with an organization trying to get people to provide more services for schizophrenia, found that some politicians of the far right were against expanding services to schizophrenia until they found they had family members with it. And they changed their mind. So part of it is to try to show it's actually, irrespective of your political spectrum, it's your interest to see if you can expand services. Just because even people that look like you will at some point or another need services as well. So the other thing, of course, is very important is that many of us have come out with campaigns, and campaigns are wonderful. However, campaigns that work are those that are sustaining. We've seen too many times which campaigns have started, and then after maybe a summer, everybody go out of town, take a vacation, it's gone. So we need to look at ways to address it. Working against it is the fact there's a huge technology now that's developing. Many advertisement and commercial people are now becoming very, very astute at using modern technology to spread misinformation. And that's something we really need to work on. I love AI, but I don't like it when they go out there and call me on the phone and come up with some crazy stuff. So we need to work on that. Yeah, the question is, what can we do now? Working, what's going on with youth, the Inner City Peace Project, to be able to address some of these disparities.
And how do we get more numbers?
And more numbers. Yeah, the good news is that there are plenty of African Americans and Latinos and other groups in this country. The problem is they do not have often access to the information and the education. What we find is that if a kid isn't exposed to science by the 10th grade, he almost certainly is not going to become a physician or a nurse. It's just not going to happen. And so part of it is to go in and to interest folks in terms of science, technology, and so forth. Full disclosure, neither of my sons are in healthcare, but they both ended up in IT because they didn't believe the thing that if you become an expert at video games, you're going to become an IT specialist. And yet that's the message that many of our kids are on. So all of us can go out and make sure that our kids are exposed. And the other myth is that if you're 5 feet tall, you're going to become a great basketball player. It is not true. And yet I frequently see young people who are literally saying, I'm going to become another Michael Jordan. 5 feet tall. I said, no. So part of it is to offer them something other than going out playing night basketball and all that, but to offer them some other exposure in terms of the community. And yet I was to be able to be mentorship. What COVID did is wiped out a lot of mentors. What we can do is make ourselves available to some of these young people. The other, we have this myth that youth is good. Well, studies show that, some folks, which is a minority, become demented late in age. Well, a lot of elderly have is wisdom. And so we're trying to get the message out that young people can benefit from being exposed to people with wisdom. And I encourage you to read the works by my colleague, D.L F.A.P.A, who's done quite a bit of work promoting wisdom as a resource that we can, those of us who are over 70 and 80 can offer.
Yes.
Amen.
Would everyone please give him a round of applause? This is a very, very insightful talk. For all of our speakers, we have a tradition to give our speakers, plant a tree in your honor. So our club is an environmental club this year, which is wonderful. And I have to present something to our club as well. But William B. Lawson, April the 24th, we are presenting this certificate to plant a tree in your honor. And also you can locate your tree by using the GPS system.